bem-vindos e bem-vindas a todos ao nosso webinário. Good morning, good afternoon, everyone. Welcome to our webinar, South-South Collaboration, a Common Data Model for Maternal Health Research. This webinar is part of a research project in partnership between Center for Data and Knowledge Integration for Health, Cidacs, Fiocruz Bahia, from Brazil, and Western Cape Provincial Health Data Center, PHDC, from South Africa. I'm Adalton, I will be your host for this webinar. Então, bom dia novamente a todos. Esse nosso webinário, Colaboração Sul-Sul, um modelo comum de dados para pesquisa em saúde materna, é um evento que é parte das atividades de um projeto em parceria entre pesquisadores aqui do Cidacs, no Brasil, e da África do Sul. As apresentações deste webinário, elas serão realizadas inteiramente em inglês, por isso vocês podem acessar a transmissão simultânea em português ou espanhol aqui no Zoom. We are pleased to offer simultaneous translation in English, in Spanish, and in Portuguese. Please use the interpretation button at the bottom of your Zoom screen to select your language. This webinar is also being broadcast live on Cidacs YouTube channel. Today, we will share presentations about our initiative on data interoperability in maternal health research. We will discuss our journey through this process, highlight key findings, and offer recommendations. We will also host a panel discussion with brilliant participants about suggestions and recommendations for our community. During the webinar, we invite you to use the chat to share your comments or ask questions to our team. Let's begin with an overview of the project. We invite Valentina Matu, who is Research Fellow at Cidacs and member of this project, to open this session. Valentina, the floor is yours.
Thank you, Adalton. Good afternoon, good morning, everyone. Thank you for being here. Next slide, please. So as Adalton mentioned, we have 3 institutions represented in the very large team that's been working over the course of the last 20 months. We have Cidacs, the Center for Data and Knowledge Integration for Health, based in Brazil, and the PHDC, or the Provincial Health Data Center of the Western Cape Department of Health from the Western Cape Province in South Africa, and SANBI, the South African National Bioinformatics Institute at the University of the Western Cape, also in South Africa. Next slide. Before we delve into the project itself and tell you about our experience, just a couple of words about our institutions. So Cidacs uses the data ecosystem available in Brazil to take advantage of real-world data to evaluate social and health policies in Brazil, study social determinants of health and social inequalities in health using information from Ministry of Health information systems and also social programs. Next slide. So while Cidacs is largely devoted to research, the PHDC aims to enhance clinical care by ensuring the availability of data to provide adequate care to all patients by harmonizing and bringing together patient-level data into a single place from routine information systems. There's, in both centers, there's a process of data curation and utilization also for research at the PHDC as well. Next slide. And finally, at SANBI, they use advanced computational methodologies and genomics data analysis to foster biomedical research in South Africa, and they have many collaborations across the African continent and worldwide, and a strong scientific presence also in our research team. Next slide. Right, so I will quickly present what our project aimed to do, how it came together, first of all, and what it aimed to do, and then I will pass on the words to my colleagues to discuss some of the challenges we faced, and then what we actually did together, managed to accomplish together. Please, next slide. So just to carry you through how this collaboration came together, we had the Gates Foundation facilitate an initial contact. It was working with both people from Cidacs, from SANBI and the PHDC, and it made an initial contact online where we shared kind of our aims and practices, a bit of getting to know each other. Then we had the opportunity, some representatives from each of these institutions met at the Grand Challenges annual meeting in 2022 in Brussels. So it was the first in-person contact where we further explored mutual interests and synergies. So we then proceeded in a next encounter, which took place on the occasion of the Global Health Network conference in 2022 also in Cape Town. We had a couple of other delegations from these institutions meet in person when we started, in fact, brainstorming a collaboration to then submit a proposal to the 2022 Grand Challenges annual meeting call to action along the scientific track of harnessing the power of data in health. Finally, we had our proposal accepted and started our project in November 2023. Next slide. Next slide, please. So our aims were threefold. First of all, we wanted to produce a common data model for studying infectious diseases that affect pregnant women in the Global South. To do this, we took advantage of the OMOP common data model curated by the Odyssey network that my colleagues will talk a bit more about later. The idea was to create this common data model and as a proof of concept, develop some prototype epidemiological analyses regarding gestational syphilis and tuberculosis infection in pregnant women in Brazil and in the Western Cape province of South Africa. And one large output that we're quite happy about sharing today is recommendations that have come from our experience in the processes that we went through and the lessons we learned for the wider communities, but also health authorities, other researchers, and the wider international common data models community. Next slide, please. Just quickly, how we organized ourselves. It was a group of 20 plus members. We organized ourselves into 3 working groups. One was a more technical working group treating data discovery and processing. It's the working group that came together to, in fact, implement the OMOP common data model with the collaborations of the epidemiologists that composed the second working group that were responsible for carrying out, thinking the analyses and carrying out the actual research. And finally, we had our third working group, which brought everyone together with a process of public engagement with science, where we involved stakeholders, relevant stakeholders from both the data health authorities side and also the more epidemiological side of the research to help us to guide us through the development of this research project and help us take the path that was most relevant in terms of knowledge creation for our wider public. So I'm passing over now to my colleague Nikki Tiffin. Thank you very much. Okay, just sorry, a quick snapshot of our encounters. We did have 2 in-person moments, 2 visits, reciprocal visits. We had the team over in Salvador in April of last year. And in September of last year, a delegation from Cidacs also went to Cape Town. And we had many moments of mutual learning and also a little pleasure on the side, some tourism, and just a great team building moments. Thank you very much, Nikki.
Thanks, Valentina. So I'm just going to speak very briefly about some of the data governance issues that we grappled with in this project, and sort of contextualizing it within global health research in general. So, of course, one of the big challenges with these data that we're working with is that they're data from real people and they're collected for the provision of healthcare. So they don't come with consent for research use. So we have to keep in mind not only this, but the Health Acts, the legislation, and Data Privacy Acts, and then, of course, showing respect for the autonomy and privacy of the healthcare clients from whom these data came. So we tried to find some solutions that we felt were ethically appropriate. So one of the first ones was to use anonymized and perturbed data sets. So this made sure that there was absolutely no way we could re-identify any data or know who the data come from. And then we also didn't share data sets between the different collaborators. So the data stayed inside their secure environment where they normally live. And in this way, you know, we tried to reduce the risks. We weren't moving data, sharing them, and we were making sure that the data can't be re-identified, but still driving the benefits, because these are fantastic data to support evidence-based healthcare innovation and progress. So we specifically wanted to pilot this approach of federated analysis because we feel that this is a way to ensure that we don't compromise the privacy of the data and the healthcare clients from whom the data originate. And we don't want to share the data onward because it's simply not appropriate given the origin of the data. So in federated analysis, what we aim to do is to have the same analyses being done on the data sets, but instead of sharing the data sets or combining the data sets, we do the same analysis separately on the different data sets, and then we bring together the results and we combine and contrast and compare the results at the results level. And if you want to read more about these sort of different ways of doing data sharing, I just gave you a link to a paper where we sort of wrote about these different options that are available when you can't just join data or share data or hand data over. So I'm going to hand over to JP from the data center, who's going to talk more about the technical barriers. Thank you.
Fantastic. Thanks, Nikki. Good morning and good afternoon, everyone. It's a pleasure speaking here today. My name is Jean-Paul Heineck. I'm a senior data engineer at the Western Cape Provincial Health Data Center. And today I'll briefly be covering the technical barriers driving the need for OMOP. Next slide. Thanks. So quickly, we're going to delve into an overview of the OMOP Common Data Model Framework. But before I get started on that, I'd probably like to draw an analogy or a tangential to why OMOP or CDMs as a whole is necessary. And that is, imagine trying to read multiple novels at once, each written in a different language with different alphabets. That's essentially a very difficult task and is what we're trying to do with a lot of the health data, where they come from different sources, different disparate sources, such as hospitals, clinics, lab, pharmacy, each speaking a slightly different dialect of data. So as we can see in the image that's presented on the slide here, on the top there, you can see those languages, or rather the raw data sources, which is, as I mentioned, the clinics, hospitals, pharmacy, and laboratory data, but it extends far beyond that. Each of them storing, patient information in their own custom systems with different formats, different codes, and under different assumptions. So OMOP steps in not only at the source, but during that transformation, where we do not change rather how the data is collected, but we harmonize how it's understood. Now, the crux of kind of that OMOP conversion takes place in that middle layer where we've got data ingestion and data integration. That's where the real work happens. We've got extraction, quality control, data linkage, de-identification, and mapping, which are not optional steps, right? They're absolutely required, and they're kind of precursors to applying OMOP on top of that. They are also where many health data projects tend to struggle and fail. OMOP offers a common structure and semantics, one set of table, one way to represent a drug, a diagnosis, a visit. It's not magic. It still requires a lot of work to map the data from those source data systems into the OMOP format. But once it's in OMOP, you unlock powerful capabilities. In that final layer at the bottom there, you can see evidence extraction or evidence generation. Once the data is harmonized into that OMOP format, you're then able to build virtual cohorts, run queries, extract insights without constantly reinventing the wheel, as well as outputs such as tools, dashboards, analytics can now operate on that known predictable structure. Importantly, maybe what I want to highlight as kind of a key takeaway of this slide is that OMOP is not a product, it's a model, a framework, and a community-driven standard. It doesn't solve all the data challenges automatically, so it's not a silver bullet, but it gives you a foundation that's technically stable, scalable, repeatable, and open source. Next slide. So taking a look at some of those technical challenges that then require OMOP, I've highlighted 4 of them, 2 of them on this slide and 2 on the next slide. So slide 1 was the story of chaos turning into structure. This slide is about why that chaos is so problematic. One of the fundamental problems is with data heterogeneity. That's where healthcare data is not just varied, but it's fragmented. So lab results might be a number with units, a diagnosis might be a code, one from 10 different coding systems. Medication might either be a brand name or chemical compound, and the list goes on. Trying to analyze these across databases with these different formats is akin to merging spreadsheets with no column headers. You just don't know what you're comparing. OMOP addresses this by saying, let's all agree on one layout, one set of terminologies. So for example, diagnosis, use SNOMED. Medications, use RxNorm. Procedures, just use some standard set of codes to describe the procedures. Then, of course, kind of tangential to the data heterogeneity also comes the inconsistent terminology. So OMOP assists thereby enforcing a global dictionary, a standard set of grammar to use in health data, which allows algorithms to be portable and insights to be comparable. So instead of rewriting logic for each different data set, researchers can use the same code base across systems, which is a massive technical leap forward. Again, it's not just plug and play, but you still need to map your local data into this OMOP structure, and that mapping is technically intensive. OMOP helps, but it doesn't eliminate the challenge. I think Chris will be speaking to some of the challenges in the next section, but I'm just highlighting that these are sort of common challenges that necessitate the use. Next slide, please. So looking at the last 2, we are now in the realm of what makes this scalable. We're going to talk about governance and privacy, so talking about technical aspects that Nikki touched on, as well as code reuse and why that is important. So in most settings, we cannot move patient-level data between institutions, not even for research. Privacy regulations and local policies make this non-negotiable, as Nikki has highlighted. What makes OMOP allow this is kind of to be a federated and analytics is to rather send the code to the data, so where the data lives. And this is akin to running a search inside of a locked vault. You don't need to remove the documents, you just need to get back a summary of the results. This is possible because OMOP defines how the data is structured, meaning the same analytic script can be deployed across multiple silos without change. And then looking at that code reuse, this is another big technical pain. We're rebuilding code for every project, such as a new study requires a new ETL, a new analysis which require new logic. OMOP shifts this by enabling a shared ecosystem of open source tools and analytic pipelines, such as Cohort Builder, Atlas, Achilles, and more. Because the data is standardized, these tools work out of the box, which is a huge engineering win and absolutely saves time in the process. This lowers the barrier to entry. Not every team needs a deep database engineering skill to run valid analyses, although the argument can be made that you actually need database engineering skills to put OMOP in place in the first place. But once it's established, you don't need those skills. You can rather focus on asking better clinical questions, not wrestling with data architecture. Thank you so much. Over to Chris.
Hello, I'm Chris Furry. I am a data engineer and an MLOps engineer for the PHDC. I am the project lead from the Western Cape side, as well as the lead on the ETL. And yeah, great to be chatting to you all today and sharing our journey in this project. Next slide. So I'm just going to start at a very high level and then progressively zoom in on our ETL that we did. So that's extract, transform, and load, the common terminology used when moving data around. And as has been mentioned, the point of OMOP is to take disparate different data sets, get them to conform to a particular standard. So that's step one. And then step two, co-develop an analysis method. And then step three, share and combine the results instead of the data itself. So I'm going to be zooming in there to step one. So next slide. So this is typically what a data transform or ETL would look like. You have some source data that you're mapping to the OMOP common data model, where you have a predefined structure and a predefined set of vocabulary that you use. So looks easy enough. Go from left to right, but let's see how hairy this can get. Next slide, please. This is from another study, just demonstrating across sort of 25 data partners in the Eden Health Network. They showed that on average it took about a year to do these kind of data transforms, and they laid out certain steps there from 1 to 6. That's a time for each. And this is sort of where we started when we started ideating around how we are going to do this within our Global South context. But I think an important thing to note here is we are also all learning and upskilling. So this is, at least in the PhDC capacity, one of our first projects for OMOP. And it's and Cidacs has only had a handful of OMOP projects. So next slide. So this is actually more or less what our process looked like here. I've highlighted specific steps that were more focused on our research groups. So we were in 3 working groups with researchers, our technologists or ops individuals. So that's myself. And our 3rd working group was the community engagement side of things. We've only represented the researchers and technologists here. So this is also a very idealized schematic of what this process looked like. And I mentioned this because I think it's important to highlight really what some of the differences are in the Global South that we experience, and particularly where we're resource constrained, and how does that materialize in a project like this. So we're addressing each one of these steps sequentially in a waterfall manner for individuals who know what that is. I think is probably the recommended way of going about this. However, because we're developing both the analysis and the ETL sort of sequentially, while also trying to sync up the work between the 2 teams. While this was the rough progress of how we worked through the project, there were in fact I call it more of like a continuum, where very often we'll go back to previous steps to update something upstream in the process as we learned and as we went along. And that really was one of the, I'd say, biggest challenges that we experienced, is not having our entire data sets already, because we're OMOPing just a subset of our data sets for a particular study, not having our entire data set that we're wanting to then OMOP, and then having that OMOP, and then trying to do 2 studies from that, which, while I think this is a pattern that does occur in the Odyssey community, I think what happens far more often is you'll have a research network analysis where the design of the analysis is fairly concrete before the ETL and the downstream tasks commence. So trying to navigate back and forth along this path with our collaborators really was quite a challenge. And I think sharing on that is probably one of the more valuable things that I can provide here for other groups in the Global South who would like to either pick up OMOP projects like this. And I'd be also really interested to hear on feedback from our panelists who have done projects themselves and how well this. I've outlined some of the boxes with sort of what sort of happens solely within our individual orgs, while the synchronous activity and syncing up between the Cidacs and the PHDC and SAMBI. And just I'd like to highlight in this diagram as well sort of two very important feedback loops between like the design and analysis phase, or the design of the analysis and specifying the variables to the actual implementation of the ETL. So often we would get to a certain point. So let's say if we go through this sequentially, once we've done our study protocol and gotten our data access approvals, and to note as well that often in these big organizations, the data access that researchers and technologists have is different because following principles of least access in terms of data security, that's a good way to segment that. So that's just something good to note. Sorry, could you go back one? Yes. So we're going on to then to compare our data sources, just because there's so much data that before we can even design the analysis, we have to understand what it is feasible. So essentially doing like a feasibility review of what variables we have so that we can move forward with an analysis like that. And then the mapping itself, while a lot of the time OMOP presents it as mapping just from our source data to the OMOP standard, what we found is it was effectively a mapping from our source, and because we're just doing a subset analysis to that analysis, and then from that to OMOP, and then from OMOP sort of back to that analysis data, and I'll expand on that in the next slide. Yes. So here on the left, we have our source data, and ideally you'd want to map straight into OMOP, but because we're doing sort of only a subset of our data specific to these analyses, I put some grayed out tables there for analysis tables sort of 1 and 2, where those would comprise all of the variables that we need to get our results. Because effectively during the ETL process, we were constructing those tables, even if it wasn't intentionally, and this is something that we really only realize on review. So those weren't tables that we constructed intentionally, but noting that that is an extra set of effort that happens in this process. And I think also the assumption, let's say in the Global North, is that the researchers are then able to use SQL to query OMOP to get at the data that they need to complete the analyses. However, I don't think this is a reasonable expectation in resource-constrained environments, and producing these sort of analysis table 1 and 2 that are simplified, often fairly wide tables that have the variables a lot easier to access is something that we found that was necessary. And I generally would expect this to be the case for more often than not, because the OMOP standard is quite verbose, meaning that you'd have the data is expressed in sort of very many tables that one would need to link across and consolidate data from, which often isn't the case from a lot of low resource data centers. Sure, next slide. So one of the tools that I found to be extraordinarily useful in syncing and dealing with this problem of going back and forth along that pipeline was having one source of truth for describe both the research or analytical plan and the data that we needed for that, as well as key elements of the ETL process itself. So on the left, you'll see an example of an analysis variable that one would need to carry this out. And then on the right, mappings for variables that are more pertinent to sort of the data engineers versus the researchers. And in the middle, the concept definitions for that come from the sort of Athena to be very specific in our definitions of what these concepts are. And while there are tools that the Odyssey network provides, because we're low resource settings, it's quite a lot to ask for multiple individuals in the team to upskill on different tools. And the intention here was using a spreadsheet, which is a tool that people are generally familiar with. And because it's collaborative, so online, we're then able to go back and forth, and having things like inline comments and versioning of documentation was very useful. So there, where there's a comment saying, is this the best choice for a concept? Having that sort of live feedback was incredibly useful. Whereas what I've seen from examples of other OMOP projects, it's often very much one segment of the project is done and then sort of handed over to the ETL team, where this was much more blended between the two. And if you go to the next slide, we can see that this can get quite a bit more involved with the type of mappings there. And just to give you an example, if you look at like that OMOP column, we'll have just to get the first antenatal visit location, to query that, you have to query across sort of 3 or 4 different tables, because you're looking for the observation, which is the antenatal visits, as well as the location, which is connected to the visits, and the care site, and eventually the location. So you're presenting that kind of a structure to epidemiologists and data scientists who aren't familiar with OMOP is one of the reasons that we wanted to have this these analysis or like derivative tables from the OMOP data. And yeah, just some more examples of what commenting looks like in those places, like why it's important, because sometimes you get this to some point of the ETL and like, does this well enough, align well enough with our plans, and like, does this data actually exist? Like, is it there? Is it clean? Are we actually able to use it? So a lot more sort of working on the fly on both the analysis and the ETL as we went. So next slide. So what I'd like to share is, I think this particular artifact from the project is, I believe, to be quite useful, because while there are tools, like I said, like Rabbit and Hats from the Odyssey network, that really looks at mapping just between like the source data and the OMOP data, and doesn't include some of that's the sort of more end-to-end and like including things like derivative tables for analyses. So I do still think that using a spreadsheet like this is incredibly useful because of how accessible it is. It may be useful to investigate other end-to-end popular mapping tools like Open Metadata or DBT, and there have been some examples of this in the Odyssey community. However, I still think that Global South, low resource settings, trying to avoid as much new tooling as possible is something that should be looked at quite intentionally. Next slide, please. So I do think that that can be reused for similar studies, and if we had to map that back to like what that looks like in our ETL, it's that sort of middle chunk from OMOP to the analysis table. That collaborative table tooling would help us provide. So for instance, if we wanted to have another Global South partner reproduce the study, often the OMOP community would provide just the cohort definitions. So I put that there, the little Atlas logo at the bottom. However, I think providing those cohort definitions in addition to a single point of truth mapping table for both like the research and the ETL side really would be a useful document to share forwards. And then that's something that we are going to be releasing as an output for this project. Next slide. And just something to consider, something like FIRE as an initial part to help with that source mapping from so source to OMOP, I think is something that might be a good next step to investigate for Global South collaborations, because FHIR does provide an iterative, or incremental benefits over, especially when we're just doing subsets of our data for particular analyses before we can contemplate, for instance, OMOPing our entire data set that we use within our institutions. I do think sort of an OMOP, a FHIR to OMOP pipeline, which again is something that has been demonstrated to work in within the Odyssey community as well, could be a compelling next sort of investigation. Yes, so next slide. And yes, now I'll be handing over to Prof. Emma Kelp for feedback on our research side of things, the epidemiological studies. Thanks.
Thanks very much, and thank you for including me in the webinar. My name is Emma Kolk. I'm a clinical epidemiologist at the Centre for Integrated Data and Epidemiological Research in Public Health, University of Cape Town, and I've been working very closely with the Western Cape PHDC on this project. So I'm going to discuss some of the sort of prototype analyses that we have conducted using data that's been mapped to OMOP, and this is basically just they sort of proof of principle analyses. The content is less important than the process. Next slide, please. So we were going to look. Infectious disease in pregnancy was the example that we're going to use as part of the broader OMOP project, and we used two conditions. One is gestational syphilis, and the other maternal TB. So in terms of the importance of these two conditions, gestational syphilis, which is syphilis, maternal syphilis during pregnancy, has serious fetal and neonatal consequences. There's routine screening, which can be done with a simple point of care diagnostic test and inexpensive treatment with penicillin, which can cure the mother and prevent congenital syphilis. Rates of congenital syphilis are a marker of access to and the quality of antenatal care, and in this form a social risk marker. And there's been a rise in gestational and congenital syphilis cases globally. So it's very relevant. In terms of maternal tuberculosis, by which I mean TB disease during pregnancy and within 6 weeks postpartum, the global burden of the disease is unknown, but South Africa has very high rates of TB, and the estimated incidence is almost 1% during pregnancy, and up to 4% of these cases are drug resistant. In Brazil, the main epidemiological relevance of looking at maternal TB is drug-resistant TB. And TB disease during pregnancy results in adverse maternal, pregnancy, and infant outcomes, as well as adverse maternal treatment, TB treatment outcomes. Next slide, please. So the primary objectives were to apply the OMOP common data model to both routine databases. This is at Cidacs and the Provincial Health Data Center, and then conduct federated analysis using based on infectious disease in pregnancy, looking at gestational syphilis and maternal TB. And the primary objectives under syphilis were to estimate the association between gestational syphilis, low birth weight, small for gestational age and prematurity, and within tuberculosis to look at the incidence of TB in pregnancy in Brazil and the Western Cape over a defined time period, and then to investigate the association between TB in pregnancy and low birth weight and infant and neonatal mortality. So it's the exposure during pregnancy and adverse pregnancy and neonatal outcomes. Next slide, please. So first we're going to look at gestational syphilis. Next slide. And what we found with both data sets and both, I suppose, epidemiological distributions of the diseases in the different countries is that we've already discussed this heterogeneity of how data is collected and the data sources. And we found that for both diseases, there were variables that were common to both the Cidacs and the PHDC dataset, and those that were in Cidacs only and not the PHDC, and those which were only collected in the Western Cape. And many of these were relevant to the specific sort of healthcare and data environment in each of the places. So differing slightly from the sort of Odyssey approach, we have devised a system of looking at 3 models. Model A is looking at core variables that are common to both data sets. Model B would be Cidacs looking at the data that they have only, and this includes a lot of socioeconomic and sociodemographic characteristics, including being a beneficiary of the conditional cash transfer. And in Model C, we would look at, we would include variables that are only collected or relevant or collected in the Western Cape. And what we're able to do with the PHDC then is to look at both active and past syphilis, look at maternal HIV status, which is very important in our context, and look at pregnancy losses and congenital syphilis. So common to Model A is using a defined time period and looking at live births only, and then some common adverse pregnancy outcomes, which we could do across systems. Next slide, please. So these are some of the data that Brazil has produced looking at gestational syphilis. I'm going to present gestational syphilis data for Brazil, and but not for the Western Cape, because the mapping of the syphilis data was far more complicated in the Western Cape dataset, and we haven't quite completed the ETL process yet. You'll also notice from this and from other slides the large numbers of people that have been included. So it's in the it's in the range of millions. And so then just to bear in mind that even small changes can often result in significance if one looks at a p-value, and so one needs to interpret it with those caveats. So in Brazil, they analyzed live births between 2011 and 2020, looking at administered data from CISNAC, which is a live birth information system. And you can see that in pregnancies, in pregnancies affected, the prevalence of gestational syphilis over the period was 0.66%. And most women who had pregnancies affected by gestational syphilis were younger, more were single, and more were single. In terms of the sort of geographic residence, more cases were reported in the southeast, and interpreting this, we think it's perhaps not necessarily related to the socioeconomic structures in the area, but more to perhaps underreporting inequalities in access to diagnosis and antenatal care in other parts of the country, which meant that there was a reporting bias towards the southeast. Next slide, please. And then what this slide demonstrates, and we'll show it again with regression, is that low birth weight was more common in pregnancies affected by gestational syphilis. APGAR score at 5 minutes was less likely to be adequate, and women were more likely to have fewer antenatal visits. So it's an indication, I suppose, that of health eating behavior versus quality of care that women have access to, leading to poorer birth outcomes. Next slide, please. Okay, and again, this is evidenced by the mother's educational level. And in Brazil, people looked at maternal race, where women of where Black women were more likely to present with gestational syphilis in the database. Next slide, please. So using both data from Model A that we both have in common and some data elements from Model B, the Cidacs conducted an adjusted analysis looking at the odds of adverse birth outcomes, and these were statistically significantly higher odds of prematurity and low birth weight in women whose pregnancies were affected by gestational syphilis after adjusting for the mother's age, marital status, level of education, ethnicity, region where she lived, and whether or not she received a conditional cash transfer. Thank you. Next slide, please. So then when we looked at maternal tuberculosis, next slide, please. We had more comprehensive data and have more experience with looking at the data in the PHDC database than we do with maternal syphilis. In the Western Cape, however, there were, again, we used the same approach. We had some common variables which we can look at. There were some variables, again, the socio-economic and demographic variables that were only in the Cidacs database that we don't have access to. And then within the Western Cape, we have information on HIV status, again, very important. Drug resistance in terms of TB, pregnancy loss, and perinatal TB. Next slide, please. So these are data from the Western Cape, descriptive data, and it's a combination of models A and B because we've included stillbirth, which is a pregnancy outcome. So in this table, it's not limited to live births, and you can see that there's almost a doubling of the prevalence of stillbirth in pregnancies affected, women with pregnancies affected by TB. And the birth weight is, the median birth weight is significantly lower in neonates born to these women. However, the prevalence of low birth weight was similar across categories. Next slide, please. There were also differences in age, in that women with TB, women who had TB during pregnancy were older, and we haven't gone into the weeds with this, but I think it might be related to concurrent or HIV infection, and we often see that women living with HIV are older than women without HIV, so it may be related to that. And there weren't statistically significant differences in the method of delivery. However, women with maternal TB were more likely to attend antenatal care early. And again, this may be related to concurrent HIV infection. Next slide, please. So we have conducted an unadjusted analysis looking at adverse pregnancy outcomes, again, prematurity and low birth weight. And the odds of premature birth was increased in the presence of TB in pregnancy. And in this analysis, low birth weight didn't change. There were no significant changes. Next slide, please. So as noted in previous discussions, there were a number of different challenges, and one of the main ones is that the different variables that were contained in the two different data sets. So we are able to conduct a federated analysis, and will conduct a federated analysis on the core variables, but more sort of granular and more granular analyses can be conducted at each site if we look at models B and C with the additional data variables. And I think also related to what was presented by JP and Chris, the challenges in consolidating all these heterogeneous data sources at various different tables into specific tables, which allowed for easy statistical analysis, was challenging and very time consuming, which is why we have only managed to get to the epidemiology towards the end of the project. However, I do think that we have demonstrated that this is possible. Next slide, please. So our next step is to apply analytical scripts for both diseases at both sites with similar scripts, and to carry out a meta-analysis of the regression results and ultimately disseminate the results. But I do think that we've succeeded in terms of the proof of principle that we are able to map our quite complex data sets using not study data and not insurance coded data, but routine operational data, where in the case of the PHDC, there might be inference in terms of how we define conditions. using the OMOP common data model and to conduct analyses. So I think it's there was an achievement in that sense. Thank you.
Thank you so much, Emma, and good afternoon and good morning, everyone. My name is Muzammil Ismail. I'm a public health medicine specialist. I'm based at the Provincial Health Data Centre in the Western Cape. And from my side, I'm really pleased to build on the presentations that have been showcased already and really trying to bring it together in terms of some of the key recommendations that have emerged out of the Cidacs PHDC collaboration on implementing a common data model or CDM in the Global South. Next slide, please. You can move to the next slide again. So the approach that we've taken is really to try and organize our thoughts into 3 working groups, as Valentina mentioned. So there's a technical working group, an epidemiological working group, as well as a community engagement working group. And across each of the working groups, we then identified the challenges. We documented some of our solutions that emerged. And from that, what lessons we learned from that in terms of taking forward towards a recommendation. Next slide. In terms of the technical working group, and this is really just surfacing a high level, some of the highlights that came up. This group, the first group, tackled a lot of the core infrastructure issues, and one of the key challenges that emerged very early on was around limited capacity and experience in applying common data models. We managed to address this by establishing and incorporating individuals quite early on with institutional knowledge that have applied CDMs and that we can then gain a level of efficiency to get going. But really the lesson learned in this regard is to consider quite early in a project like this, support from, for example, the Odyssey community so that the learning curve is brought down to a manageable level. The second big challenge, I think, is around computational space. Running large ETLs is memory intensive, and some of the solutions that we came up with was to create submachines in our subspaces on our virtual machines, adopting files that are a lot more efficient and optimizing our storage, and really to consider as technical teams wanting to go down this path, to be able to plan ahead of time a dedicated infrastructure to support this process. And then finally, we have to acknowledge that there is certainly an asymmetry in the resources between the Global South and the Global North. OMOP can be quite resource heavy to run. And in order for us to sustain success, to scale the value from using common data models, we do require continued support from global research funders to help make CDM implementable and viable in a public health sector setting. Next slide. In terms of working group 2 from an epidemiological perspective, there's a couple of things that emerge. The first is aligning our analysis design across different countries. That wasn't really a straightforward task at all. We found that the analysis design had to be quite dynamic and it needs to be adjustable to what is feasible in each data set. And another related issue to that is the potential loss of contextual information if we only work on common data that's available in both settings. So in order for us to preserve the richness that exists in both data sets, we're running 3 parallel analyses. A shared model, which is common across both sites, and then 2 site-specific models, one for Cidacs and one for PHDC. And what that does, therefore, is allow us to maintain fidelity and replicability in the common model, but still maintain a level of insight and nuance as it relates to each respective context. Next slide. From a community engagement perspective, we try to really focus on lifting up the voices from the community and ensuring that stakeholders are included, that their voices are heard, that their recommendations are then therefore put forward. And what we did, we sampled our community and we then categorized some of the themes based on the background of the people that responded. The theme that was quite clear from public bodies, which includes government departments and developmental agencies, was a theme of fostering and continuing to foster multidisciplinary collaborations like this, but not just between academic institutions, but also inclusive of government, inclusive of the private sector and civil society to support OMOP uptake. And then linked to that, once those kind of collaborations are set up, it opens up the door to go about applying for joint funding and responding to joint funding calls. And with that comes a level of comfort that there is clear governance around data fidelity, data integrity, and that each country's respective data privacy laws are taken into account. From an academic institution and research team perspective, there was a clear push and a strong intention towards providing detailed documentation on OMOP model tables, the need to share data dictionaries, and a need to ensure that analyses in each respective space still maintains the contextual reality and data and additional data that might not be form part of the common model. From a health professional perspective, there does require a need for ongoing training to understand what this means and how it actually applies to day-to-day practice, how it fits into the health data lifecycle, both in terms of creation of new tools, variables, and how that needs to link, what the value is when linking to common data models. And then linked to that as well is to look at what the impact of federated analysis are on healthcare outcomes. And then lastly, communication specialists. This is quite a complex topic, and therefore there is a clear need for us to be able to translate complex technical insights into accessible materials, be able to share good practices across different teams, and then to establish feedback loops where we can understand if the target audience is actually understanding what it is that we are communicating. Next slide. And just to end off essentially in terms of recommendations, I think looking ahead, this collaboration has certainly taught us many valuable lessons about federated data science. Our experience illustrates that CDMs are feasible, but they're not feasible without careful planning. That workflows need to be adaptable, that we need to have strong governance, and there needs to be an intentional community engagement aspect included as well. With that, I certainly hope that these reflections and recommendations offer some useful guidance for others, both in the Global South and beyond, who are also embarking on this journey. And I'm looking forward to hearing the panel discussion that's to follow. So with that, I'll stop there and hand over back to you, Dalton. Thank you so much.
Thank you, Musamil. Thank you, everyone, the team. Now we will start the debate portion of our webinar. The purpose of the panel is to continue this discussion on challenges and recommendations surrounding health common data models. And we invite you to share your insights, questions, comments regarding to our presentations. You can use a chat on Zoom or on YouTube. But we are also very happy for the opportunity to have here with us 4 fantastic experts who will share their views on the use of common data models in health. We will have Agnes Kiraga, Catherine Johnston, Michael Ochola, and Emily Taylor. I'm going to start with Agnes Kiraga. She's Head of Data Science Program and Research Scientist at African Population Health Research Consortium in Nairobi, in Kenya. Agnes, you have 2 minutes to start sharing your first insights, questions for team, recommendations for our community. You are free. Welcome to our webinar.
All right. Thank you so much, Adalton. And to the presenters, it's really been exciting to see how you've really gone across this challenge, if we still consider it as a challenge, and using the OMOP common data to address different aspects of evidence generation And speaking on behalf of the APHRC, but most importantly, on behalf of the Africa chapter for the Odyssey community. And I know a couple of colleagues who are here. And the experience, the challenges, the recommendations really attest to the discussions that we always have in the Africa chapter and how to really operationalize the use of OMOP and scale it for different use cases on the continent. I had several comments from all the presentations, but I know I only have 3 minutes to give all the other panelists a chance. And I wanted to start really with the comment around the data governance and the federation. I think this speaks to most of our challenges we are facing on the continent, an area that has almost 32 different data governance policies and data protection acts. It becomes even more challenging to have sensitive data primarily moving from one country to the other, and seeing this expanded even to another continent, like and seeing this in Brazil as well is reassuring that we are all tackling the same issue. And I wanted to really get insights around the federation, and I know Nikki mentioned it, and also the last speaker, on what has been the exact infrastructure that has been used to conduct this federation, and any lessons learned on how this has actually worked out, what exact investments were needed to have the real deployment of federation, which at sometimes is always confused with a meta-analysis. So I think I'd also want to get your insights there. The other issue really that speaks to some of the challenges we also often encounter on the African chapter is around the mapping and different concepts. And I saw different variables here around socioeconomic variables like conditional cash transfers, professions, and ethnicity. And I know some were present in the Brazilian data set and not in the South African, or vice versa. But again, listening to you, it brings back some of the experiences we also often encounter, and again raises the need for us as a continent or South-to-South collaborations to raise some of these new concepts and how we can modify these. And I know some of the colleagues here in the African chapter have been discussing this. Again, if we can get a list of these variables and have these terminologies updated with some of these very unique variables that speak to only different settings, it will be great. The third is around, I know AI is a buzzword. Do we see the place for AI in helping the whole journey of mapping and ETL creation? How can we think of different tools that are coming on board to help us make this tool or this process less painful? I like the graph that Chris showed, the different, the time spent on the different activities. How do we see the role of AI supporting some of these activities? And of course, some of the colleagues here have probably started that journey, and different tools that are being developed like Jackalope and others are being put out there that we can share, and also see how we can leverage this experience to help with making the whole harmonizing and analysis even easier. The other were really comments to Emma around the analysis, and I think I'll skip those for now and give my other panelists a chance, but just to re-echo the fact that the African chapter is very open to some of these discussions. In fact, we had a meeting yesterday and we talked about different aspects of the languages that we use during the mapping, the languages that might be in one way infiltrated in the way we interpret variables that might affect the way the variables, the data is mapped. So we really encourage the team here to join the Africa Odyssey chapter meeting. I know Cynthia is here. She'll also provide some comments later so that we can have the discussion comprehensive, and also see how we can move forward with the challenges that we are encountering, and also the recommendations that you proposed. So I'll stop here for now, and thank you to the entire team for the very great presentation. Over.
Thank you so much, Agnes, for your comments, invitations, etc. We are going now to hear from Emily Taylor. Her comments, she's lecturer in artificial intelligence at Malawi University of Business and Applied Science. And it's your turn to share your insights. Emily, welcome to our webinar.
Thank you very much. Thank you for the invitation and thank you for the wonderful presentation. I'm also here in the capacity of a member of the Inspire Network. So the Inspire Network, which I joined as part of a project that used OMOP and Odyssey, so similar type of technologies to analyze data, COVID-19 data from Malawi and Kenya. So during that project, I was introduced to Odyssey OMOP. So this is something that was quite new to me in 2020/2021. And since then, we've embarked on a data standardization and ETL to OMOP for HIV data in Malawi. So this was data that is coming from multiple facilities and is aggregated at a national level in a common database or data lake. So part of that ETL experience, I can see some common opportunities and challenges in terms of what you've presented. And I just wanted to talk about three. So one is data standardization. It would be good to understand the extent to which the data that you were dealing with was standardized. Were there any vocabularies that were used, maybe intermediate? So the OMOP Odyssey Common Data Model is using, it doesn't have its own vocabulary, but is using a hierarchy of vocabularies that are connected with each other. So you have vocabularies for conditions, diagnosis, drugs, measurements, and so on. So in the case of the Malawi data, there was some standardization using ICD concepts. So that means that the data standardization work is bigger. So it's much more maybe time intensive and effort intensive and probably even costly for data sets that are not, using a lot of medical vocabularies or health vocabularies. The second thing that we've learned or encountered is how to develop analysis, or what kind of analysis, formulate the analysis that are supported by the OMOP Odyssey framework. So bearing in mind that this framework is designed to work for longitudinal health data, so that refers to defining cohorts of patients that satisfy specific characteristics, and then trying to either characterize them or maybe predict something. So one of the things we discovered is that this type of analysis weren't, let's say, so obvious even to people who have been working with this data, mainly because the large data has been used historically for aggregate statistics. So generating, statistics for specific indicators. So some of the detail, let's say, patient level or cohort level analysis wasn't necessarily formulated. So that became part of the work. So, that also means that there is an added effort and added expertise that has to come on the table, in the team. And the third one really refers to data quality, because especially when you deal with longitudinal data where you want to look at events and dates, so you want to follow patients over time, some of these gaps in the data can have a big impact. Also in terms of modeling, how to model it into the common data model, but also how to analyze it. So we found, I found that, a lot of the work became detective work. So trying to understand, how is, the data that we were looking at in terms of the coverage, and so granular at the patient level, and then also at the cohort level, if we were to analyze cohorts. So yeah, and maybe just to say here, parentheses, I don't know how it's in Brazil, but when it comes to health data, a lot of the data gathering or collection or data warehousing is left to ICT professionals. So sometimes the modelers or the people who actually utilize the data don't have an input into how this data is captured, which leads to more complications when you're doing this kind of work of clean, because data standardization requires cleaning also, and data preparation work. So that now raises questions in terms of, changes in the interface that captured the data, where do the data gaps come from? So overall, I felt that this process it has to be integrated maybe earlier, or in the design of the data warehousing, or how the data is being, stored at a maybe national level or facility level. And it has been a beneficial process to arrive at a better data and better analysis. So thank you very much.
Thank you, Pamela, for some great insights. We are going now to, I will ask the team to take notes, because after this first round, we are going to make some comments about the questions and the comments shared by our inviters. But now I'm going to pass over to Michael Ochola. He's data scientist at African Population and Health Research Center. Michael, the floor is yours.
Thank you very much for having me. Yes, I'm a data scientist based in APHRC, which is here in Nairobi, Kenya. So we also have some experiences working with the OMOP Common Data Model. And as Amelia has alluded, this actually started from the collaboration work we did with Malawi on COVID-19 data, and a number of learnings that has taken place. Of course, we've moved on to iterate that on new projects around data standardization and harmonization. So I just had some few remarks to actually also add on top of what has already been mentioned. So one of the presenters, I think that was Chris or Juan, maybe one of them, talked about where they were adding vocabularies on that Google or the Excel sheet. I think, yeah, that's a good way to work collaboratively. There's a project we've worked on that also we were adding, we were creating mental health standardization to the OMOP Common Data Model. And also for the sake of mental health, we had a number of mental health tools, so like different mental health tools from different data producers. And we were able to collect this on what we were calling a staging database. So this allowed us to list all the concepts that we are using for that particular standardization work. But the beauty of that is that you can actually now convert that your Excel sheet into a relational table, and that would give you a way to keep track of some of your non-standard concepts. And as actually was mentioned by Agnes, that there are now tools that are allowing us to kind of onboard some of these non-standard concepts into Odyssey. So this will look like a place to go and be able to add additionally non or missing concepts to your analysis. This is a challenge that I think is not unique to Cidacs and the team from South Africa. Some of these OMOP concepts or standard codes might be missing for a particular study, and going ahead to have a way to warehouse some of these concepts is something that the team can take forward, and then this can be moved from one project to another. So and also helps you keep track of some of these standard concepts that can also be shared with the greater wider community. My next point is more of like a clarification. There's the point that was mentioned about analysis 1 and analysis 2 on that pipeline from different tables to OMOP. The utility of analysis 1 and analysis 2 tables was not very clearly captured from my end. Maybe that can be elaborated, and then also we can take advantage of that on some of the things that we are doing. And then lastly, not to take much of the time, is to also ask, I wanted to see something on Atlas analysis, if that is a tool that was used to do any form of analytics, and if that was used, what are some of the challenges? Because Atlas also has some of limitations that we have experienced, and just to find out if this cuts across for your team as well. Yeah, I think I'll stop it at that, and maybe I will have more questions if there's more time. All right.
Thank you, Michael. We are going to hear only Catherine before the team started to ask your questions. So I'm going to hand over to Catherine Johnston. She's an experienced clinical research data manager at the University of Cape Town. Welcome to our webinar, Catherine.
Thank you. Thank you very much for having me. It's been really interesting to hear what Cidacs and the PHDC have been doing. So as you were saying, I have a little bit of experience in data harmonization, and I'm part of the data science initiative in Africa, and within that AWASI, which is building the open data science platform. So we've been looking really at metadata harmonization, and also building federated workspaces for data analysis and data sharing. And so it's really interesting to hear about what you've been doing, especially in setting up federated OMOP implementation. I think the first thing that I latched onto was, I think JP was talking about those analysis tables, and I was thinking about the feasibility of harmonization in the first place. It sounds like the feasibility of what could be harmonized and what analysis you could run as a result of that was quite important, and there was a lot of going back and forth as the data was mapped, and you kind of were able to unpack what data you had to be able to know how to map your data. And it's interesting to me because we've been working on mapping tools, and what came up while we were doing that was the first step would be really to look at feasibility. And so I think, as Amelia was saying, and Agnes also mentioned about AI, we've been looking into, can we use AI to speed up that process? Can we use AI tools to kind of cluster data commonalities and work out whether a harmonization of data to achieve the analysis that you want is feasible in the first place? So it'd be interesting to know a little bit more about that process, and to think about whether there are alternative methods to do, rather than jumping backwards and forwards between the common data model mapping and implementation. The other thing that was interesting to me was the talk at the end about speaking to stakeholders and policymakers, and how can you collaborate and share what you're learning. I think this is a great opportunity you're doing right now to share your experiences. And I think the more people do this, the better for everybody who's trying to implement OMOP. So it'd be nice to know if there are spaces where people can share the mappings that they've used and the standardized vocabularies that they've chosen to implement. And also think about policymakers, excuse me, and what their interests and whether there's some common health goals across investors and funders in that space, and what kind of funding is availability. Because, excuse me, I think that there was a lot of mention about low resource settings that we're working in, and I think that's really a critical point. I think the barriers to implementing OMOP are often the lack of resources and time that's available to learn the new tools and to make these implementations. So finding those collaborative goals is really key to reducing the costs and making this feasible. And then lastly, I was interested about whether there was any other thoughts about mapping data and putting it to the common data model for harmonization with other data types. So we've been looking a little bit beyond just mapping the health data sets, but thinking how can we downstream link it to other data like geolocator information and climate data. I wondered if there'd been any goals or experiences in kind of readying the data for that kind of interaction. Thanks very much.
Thank you for your questions, Catherine. So I'm going to pose some questions for our team based on the comments of our panelists. First, I would like to call JP or Chris to talk about some of the questions that Agnes posed to us about the infrastructure for federation analysis, and if you could talk more about that, and how is AI relevant in this process? Chris, are you there, Chris or JP?
Hi, thanks, Adolfo. And thanks, everyone. I really appreciate all the feedback from the panelists. It's so great to have these kind of insights shared here. So there are a couple questions there that I'm just going to try and address the ones that I think I'm best suited to address while I have the mic, and then I will pass the mic to the next individual. So I'm going to try and answer sort of multiple questions from across panelists, and then go across. So just to start, Agnes's question on infrastructure for federation. So I think federation is used quite loosely in different ways, and I think it's good to distinguish things like federated learning versus just general federation in terms of analyses. So federated learning would be like a machine learning approach where models are trained on data in silos, and then the weights are averaged or shared with the data not being shared. This is not what we're doing here. In this case, we were federating the analyses. So the data is not being shared, but because we're using a common data model, and I think it's important to note that even if you're doing federated learning, you still need a common data model for those machine learning algorithms to run on. So this would sort of be a first step to something like that. So the federation comes in at the point of the shared analyses and combining those results. There are other approaches where you can do things like secure multi-party compute, where that sort of analysis step is automated, and the data doesn't leave the host organization's secure data environment. But we weren't doing that. We were kind of just taking the sort of first simplest step to validate that just the common data model aspect of federated analyses is feasible and then what that looks like, specifically for OMOP in a Global South context. And then both Agnes and Catherine asked about AI tooling. So I do have a background in AI. And I think we're in a very interesting space now where it's really rapidly advancing. And I think, just in my own experience now within the project, doing the OMOP sort of from a space where our source data wasn't necessarily using any existing common data model, so not mapping that to OMOP versus mapping from OMOP back to an analysis table. Those two processes, when you're using, let's say, AI tooling to map and generate SQL code or Python code or R code in spaces where there's a lot of very good documentation and those standards exist and these foundation models have been trained on them, that goes a lot quicker. So the example here is it took us some months, 4 or 5 months to do the ETL, and it took me sort of 2 days to do the analysis table, going in the other direction, which is just like a really massive ease of directionality there. And I think we really should look at it seriously and ask ourselves, how is this going to impact us? And Catherine, I really liked the idea of using AI then to try and see what is actually feasible between two data partners. I'd be really interested to know more about what's going on in that work. I have attended 1 or 2 Odyssey chapters, meetings on where they used generative AI. However, I was hoping that they would have tooling to help with the ETL, but I think it is not as aligned with that, but I might be mistaken. They are very welcoming, so if anyone is interested in that, I very highly recommend attending those open meetings. So I do think that while we didn't use, I use AI mostly in this process just for interacting with the OMOP database in terms of SQL queries. I found that very useful, and I think it does particularly well on SQL. What else can I answer here? I think, oops, sorry, I've got a cat jumping on my back. I think I will perhaps, sorry, are there spaces to share mapping used and standard vocabulary? Yes, absolutely. I think that, and this is one of Catherine's questions. One of the outputs that we want to have for the project, so when we do close it off at the end of July, will be that collaborative worksheet, spreadsheet with the vocabulary information, and the OMOP table and variable mapping to the analysis variables or the derivative table variables that we used. And if we hand that over, then if someone wants to pick that up, essentially it's just mapping then to those predefined OMOP tables and variables. But again, one would have to first do that feasibility analysis to see if that kind of analysis is actually feasible within their context, and those variables do exist in some way in their source data. But yeah, I think that's all for me for now, and I'll hand the mic back to Adalton, and maybe Valentina can speak to some of the other topics.
Okay, great, thank you. I'm going to pass the word to Valentina, and then we also have some questions from the audience, and we are going to post that here for you too. Valentina, it's with you.
Thank you, Adalton. Thank you, everyone, and the panelists for your great questions and suggestions. Definitely, there is scope for more exchanges, and thank you, Agnes, for the invite to participate in the Africa chapter. I believe Chris does accompany the group. I do have a logistical scheduling conflict, but we will try best to join that space so that we can discuss more about mutual challenges and find mutual solutions. So I will try to answer overall, bringing together a few of the questions. First of all, regarding the utilization of standardized concepts, or whether we were delving into maybe non-standardized concepts, our group did make a joint decision to use only standardized concepts from standardized vocabularies with reproducibility in mind. The idea was to produce something that we knew that could be reproduced in other places potentially. So this was not an easy decision. There were a lot of new vocabularies, non-standardized, that could have helped us map our data maybe more directly. But we did make an effort to always stick to, both in terms of vocabularies and tables, what was currently being used by the community applying the OMOP common data model, with always imagining that we'll try to apply what's currently being used and currently adopted to then make suggestions for necessary modifications. One of them that comes to mind is, I believe, I think it was Agnes maybe asked about our socio-demographic data. A lot of that had to go in the observation table. It was not contemplated, it could not fit in any other of the tables. And this, aside from a theoretical limitation, at least in my view, is a theoretical limitation of resorting to the observation table, also turned out to be a technical limitation, because an observation table became very, very large, especially for the, sorry, I think might have broken up a little bit on my side. So especially on the Cidacs side, we had some difficulties running the ETL for the observation table, because such a large data set with a large table that included so many concepts that we wish could be distributed into more specific, perhaps socio-demographic tables. And connecting this to the existence of new tables, Catherine asked about geolocated variables. We have not managed to get to that. It was in our horizon to start using what the Odyssey community has been developing and using in the over the last year, last few months, the GIS tables to talk about whether is socioeconomic context or even climate. We have not gotten to the point of being able to explore that part, but it is on our horizon. So obviously we'll hope to have an opportunity to exchange experiences with you as well on this as we address this now in next steps. And there was a question from Michael about the multiple analysis, since it's moving away a little bit from the specific creation of the common data model. The reason for the multiple analysis, Michael, was that we faced some internal questioning from our institutions with regards to what we lose in terms of information when we try to standardize to a common data model. So we were aware, Cidacs works a lot with socioeconomic determinants of health, and for us it's a great loss in the knowledge created regarding the health of the population when we lose sight, when we can't include this information in our analysis. As Emma mentioned, we included in our analysis the mother's race, because it is recognized in Brazil that that's a social variable that affects the outcomes in health for the population, for at least part of the population. So the greater part of the population, in fact. So the idea was, okay, let's land on a common model that we can both contemplate from data from both institutions, and then we'll run parallel analysis, including other variables, to kind of see what are we losing sight of when we land on the common data model. So the idea was to implement it, do a federated analysis, but then also be able to constructively criticize it, so that we can point out the necessity to include other forms of looking at, the population's health that's not strictly biomedical, clinical, as the current practice or the last few years' practice in the Odyssey community has tended to be. But we have received very open, we've been arguing in favor of doing this in the Odyssey community in various working groups, and people have been hearing us out, and we're hoping that we can move forward as the open community that the Odyssey is, to try and integrate these different aspects that affect the health, aside from the most standard, strictly health system related variables that we're accustomed to studying. I hope that answers all the pending questions. Oh, and about Atlas, sorry, very specific question about Atlas. We did have some limitation regarding installing it in our secure environment that has no internet connection. So we were not able to use the tool because we cannot take it to our data, nor take our data to it, to the cloud, for example. So we have explored the use of synthetic data sets to try and take advantage of that tool as well, but have not quite gotten around to it yet. I believe that's it. Thank you, everyone.
Thank you, Valentina. We have some questions from the audience. I'm going to read here, and anyone from the team or the panelists can answer. The first question, I'm going to put all the questions together because of our time. Daniel has asked if our opinion about the limitations of federated analysis in contrast to analyzing of centralized data sets. And he asked also, are there any analyses that wouldn't be possible for federated analysis? And another question from Daniel is about the investments. What investments are we looking at in aspiration of harmonized data sets in line with common data model across institutions and sites? And Ana Paula has asked about the mappings, if the mappings are also open source and which terminologies and vocabularies were used. So anyone here is free to answer those questions.
And Dalton, I think I'll jump in because I did mean to answer, and then maybe Chris can complement. So I believe some of these questions were answered either because some of the questions were asked at the beginning of the presentation, so maybe some of them have been answered already through the presentation and some of these questions that Chris and I gave. There was one question from Ana Paula in the Q&A about why Brazil and South Africa. So it was not a calculated thing necessarily. There was synergic moment where these two institutions came in contact with each other. We realized we have similar objectives in terms of creating knowledge regarding the health of the population. And although several differences, also some significant similarities in terms of historical context and socioeconomic development, let's call it, level. So similar trajectories, let's say. So we thought that even though we're aware that obviously there's some significant epidemiological differences between these two populations, the similarities were enough to justify trying to do a federated analysis across these two countries. And also the plan was to kind of come together and learn together how to do this common data model application in the global south. Chris, did you want to comment?
Yeah, I think I also just wanted to address a question that I didn't get to from Catherine. I think also just talking about the data quality, and how do you address gaps in the data quality? So I think we're lucky in that both PHDC and Cidacs are fairly mature institutions that, the data that we were getting were sort of at the level of a health data registry or health information exchange. So they had already been quite significant cleaning and harmonization done. Having said that, I do during the ETL process, ensuring that, we also then synced up various dates to say, well, between this year and that year, this is where we have sufficient data. So having knowledge of where our data was complete, so that we used complete data, was very intentional and directed. But yeah, during the ETL, I think just as a general comment, we both used data quality checks sort of at various segments of the ETL, as well as the Odyssey tooling right at the end. So they have the Achilles tooling that we use just to do sort of final checks on our data quality when it comes down to not so much gaps in the data, but rather, let's say, artifacts from arising from the complexities that data transformations bring up. So if there are any potential duplications of data or anything like that. So I think there's the data quality ahead of time and the data quality during the ETL concerns that were addressed. And I hope that answers that question. Yes.
Okay, Chris. Thank you. Now, I'd like to invite Musamil to share some closing remarks as we are close to the end of our webinar. Musamil, feel.
Amazing. Thank you so much, Dalton. Fascinating discussions. Amazing to hear the comments and the feedbacks. From my side, I have the privilege of closing the session today. So let me start off just by saying a big thank you for all of you for joining us today for this rich and really forward-looking conversation on building a South-South common data model for real-world health research. I think my reflections is really over the course of this webinar, we've seen how a collaboration between Cidacs, the PHDC, and Zambia has taken shape from the initial introductions that Valentina showcased to something that's quite tangible, that's proudly shared in a collaborative project in its true sense. And I think the journey for me personally has shown what is possible when institutions like this, with diverse strengths, when they come together and work towards a common goal. We've certainly explored how federated data approaches like OMOP can really unlock new analytical possibilities, while at the same time respecting ethical and governance concerns that rightfully and legitimately countries hold. The real-world case studies on gestational syphilis and maternal TBS that Emma showcased has certainly shown not only the epidemiological burden, but also the power of using data models that are collaborative and then its impact in terms of informing public health understanding. And then maybe just to say that, across the working groups, both the technical, the epidemiological, and the community engagement working groups, each group showcased and highlighted challenges. But more importantly, what came through is that they showcased solutions. And those solutions are context sensitive, they are scalable, and they're built on mutual learning and respect for each other's settings. So as we close off, I really just want to thank our co-hosting and collaborating organizations, Cidacs at Fiocruz, the PHDC at the Western Cape Department of Health, and Zambia at the University of the Western Cape. So your leadership, your technical ingenuity, and your commitment to equity-driven research has made this initiative the success that it is today. To all our speakers, our panelists, our technical teams, and our attendees, thank you for the engagement, for your questions and your insights. And we certainly hope today's discussions have sparked ideas, have opened doors, and built some bridges that will carry this work forward in even more impactful ways. And the last thing I'll say is that I just want to make an appeal for us to continue continue this collaboration and to continue questioning and innovating using common data models. So that with that, I'll say thank you so much, muito obrigado, and back to you, Dalton.
Thank you, Musamil. Thank you, everyone, for your participation. Just a reminder you, this webinar will be available on Cidacs YouTube channel, where you can rewatch or you can share it with your network. I'm going to share here in the chat. You can also find more information about our project in our website. So we are deeply grateful for your participation today. Thank you so much. Have a wonderful week.
Thank you. Bye-bye.
Thanks, everyone. Good evening.
Thank you.
Thank you. Bye-bye.
Thank you and bye-bye.